guys, welcome to Inside Fitness. I'm Megan and this is Christina, and today we're going to be talking about the general guidelines of fitness.
Before starting any exercise program, you really want to make sure that you understand the fundamentals of both aerobic exercise and strength training. If you're able to incorporate both of these into your workout, then you'll make sure you're training your body at the maximum capacity, adding variety and making it a little more fun.
That's right, and the American College of Sports Medicine recommends a minimum of 5 days per week and 30 minutes per day to equal at least a minimum of 150 minutes per week of aerobic exercise.
So that's for aerobics, but also there is strength training. We also recommend that you do your strength training at least 2 to 3 times a week per muscle group.
But your muscles do need adequate rest time in between workouts, so be sure to rest them for 48 hours in between each workout session.
So quit making excuses. Your workout is only 30 minutes a day, and that's the 2% part of your day that's going to make 100% of the difference.
So there are 5 health-related components of fitness that you really need to focus on, and you never ever want to skip leg day.
Exactly. The first one is going to be cardio endurance, or affectionately referred to as cardio. Now, when you're first starting to work out, this is something that's going to be raising your heart rate and really putting you in that optimal fat-burning state. So in doing this, you want to be able to walk brisk enough to where you can still carry a conversation, but it's a little bit laborious. And as you get in better shape, you'll be able to increase that to jogging or running. If you are worried about your joints, however, there are a couple other options for you to be able to do, like the cycle or the elliptical. Then we have the muscle strength and muscle endurance. When you're lifting weights, the actual weight that you're lifting pertains to your strength, and the endurance pertains to how many reps or repetitions. When first starting out any workout, I recommend trying any muscle strength endurance exercise 3 sets of 10.
Now there's flexibility, and you never want to forget to stretch. Stretching is really important after every workout because as you're lifting weights and as you're getting stronger, your muscles are actually going to become stiff. Flexibility stretches your tendons and it makes room for muscle growth, and it feels really good after a workout. Then we also have body composition, which is determined by the percentages of fat, muscle, bone, and water that's in the human body. Now, body composition is what determines our leanness, so don't pay so much attention to the number on the scale. It's more about what your body is made up of.
All right, guys, we've given you a lot to think about this week. We will be back here same time next week for Inside Fitness. Make sure that you're doing those 30-minute workouts, you're incorporating your aerobics and your strength training. Always stay hydrated and remember to stretch. We'll see you next week.
We're back with Dr. Bevan-Thomas. Dr. Thomas, let's talk about prostate cancer. How common is prostate cancer?
So prostate cancer is unfortunately very common. So if we look statistically, a man's risk of developing prostate cancer in his lifetime is roughly about 1 in 6 to 1 in 7. So if we look at it to pure numbers, which I think is important for patients, is that it's, in 2015, it's estimated that roughly 220,000 men will be diagnosed with prostate cancer. So one of the challenges with prostate cancer is, like testosterone in prostate cancer as well, is that, we have unfortunately these myths out there and these fallacies, which is prostate cancer is all an indolent and benign disease. Now, that's partially correct, and I think one of the things that we have to look at is how many people die of prostate cancer. Roughly 27,000 men, to be estimated, it's about 27,500 men die of prostate cancer every year. It is a legitimate disease. It is the second most common risk of death, second only to lung cancer. People will die of this disease, and it's an important fact to understand because people think prostate cancer and nobody dies of that, right? It's also a very important thing to realize is that not all prostate cancer behaves the same. So we can have patients with low-grade cancer, we have patients with intermediate-grade cancer and high-grade cancer. And it's important that you don't, I tell people this all the time, don't go over to the golf course and say, well, oh yeah, nobody dies of prostate cancer. I had prostate cancer and I'm just following it, because it's a different spectrum of diseases.
So how do you know which patients have the more indolent form versus the more benign form?
Yeah, and that is a $64,000 question that we address every day. So, how do we detect prostate cancer? That's the first question we always ask ourselves. And we still actually, number one is we'll do a physical exam. So we still have the, the infamous rectal exam, which all men, of course, dread. And the second thing is a PSA. And the PSA is a blood test. And when we look at that blood test, PSA stands for prostate-specific antigen. It's a protein, and that protein is produced by the prostate. And then basically, I tell people it's sort of like the prostate's a leaky pipe, and it leaks a little bit out through the bloodstream. bloodstream. But if that pipe is leaking a lot, we got some problems. So as that PSA, again, gets out in the bloodstream and we start seeing that high, we then find that man is at risk of having a focus of cancer. So what we've been doing, for quite some time now, is that if a man presents either with that abnormal rectal exam or with that PSA, that blood test which is elevated, we bring them in, we'll validate that PSA to, again, make sure that that's elevated. And normally right now it's above 2.5 or 3. So if you're a man with an elevated PSA above 2.5 or 3, we'll say, you know what, it's at least a good idea for us to investigate whether we need to do a biopsy. The only way we know whether a man has, whether it's low grade, intermediate grade, or high grade cancer, unfortunately, is to get tissue. And the way that we do that is actually do that prostate biopsy.
So now, can you have prostate cancer and have a normal PSA?
You can. And this is one of the challenges, is that, roughly about 20%, and somewhere in the ballpark about 10 to 20% of men actually can have a normal PSA. Of course, what's your definition of a normal PSA? When the PSA test first came out in the late 1980s and really 1990s, when we started testing and actually screening for prostate cancer, we used a PSA cutoff of 4.0. But if we used a cutoff PSA of 1.0, we would still find roughly about 10% of men actually had a focus of cancer. So we wanted to find that happy medium that we're really not missing a bunch of these patients. But give or take, it's about 2.5 or 3. As men get older, you might want to raise that just a tad, but the bottom line is that as PSA gets higher, increased risk in that. But you're right. The problem is that there are those men that have a normal PSA and have a risk of prostate cancer. So that's where the rectal exam comes in. That PSA is, let's make it up and say it's 1.8, but we do that rectal exam and we actually feel a bump on the prostate and we say, you know what, we really want to make sure that we're not missing anything, and then we'll find that focus of cancer.
And how often is a prostate biopsy positive in a situation where you have an elevated PSA?
Right. So what happens is that as that, and it is a linear progression, which is that as that PSA continues to increase, there's a higher risk that that man can have a focus of cancer. One of the challenges that we've had, at least more recently, is actually finding those cancers. What we do is we actually will do, man walks in exactly like you and says, okay, I've got a PSA of 2.7, we'll do a biopsy. We'll do the biopsy, again, we'll sample, and we try to target it. USMD will actually try to target specific areas in the prostate, but we may miss something. And the risk of finding what we call a significant focus of cancer is still relatively low. It's roughly below about 20%. But now what's happened is things have changed. So now we're starting to use more imaging technologies to help us find those cancers. So what we'll do now is we'll do MRIs, and the MRI, which has become much better these days, will find a lesion which may be significant. We then pull that MRI over to that ultrasound, and then we'll target that lesion. So now we've increased our detection methods, but give or take about double for men either with a previous negative biopsy or men exactly who walk in with a PSA of 3 or 4, so we can target lesions that we can actually see under imaging studies.
How painful is prostate biopsy?
So that's, and that's a tough one. I mean, there are patients that actually say, and come into our office and say, man, I just feel like I was completely tortured on this. So a lot of this actually does a couple of things. Number one is that it's no fun. I'll tell people it's like a 10-minute rectal exam. And again, there's nothing fun about a 10-minute rectal exam. But the bottom line is that what people mainly have discomfort with is the actual biopsy itself. So we're very good, and I pride ourselves on this in the fact that if we can anesthetize, so we'll put lidocaine, numbing medication, around the prostate. So before we actually do those biopsies, all those men should feel is sort of a little flick for the most part. So they're going to feel pressure, but they shouldn't feel anything sharp. If they do, and again, we do about 95, 80% of these actually at our office, is that we can always give them more lidocaine or more numbing medication so they actually just have very minimal issues. And we've actually done that, and we've asked our patients, and they say, you know what, this was a lot easier than I actually thought it was going to be.
Any complications with prostate biopsies?
So we do. And so what's happened over the last 10 years is that we've had an overuse of antibiotics. And that's one of the biggest challenges, is that if we use too many antibiotics, we run the risk of infection. So one of the risks of infection is infection. So we want to make sure that we're treating them with the appropriate antibiotics to minimize the chance of actually developing an infection. We target that down. So we want to make sure that, again, if the appropriate antibiotic is used, we can minimize that infection at less than 1%.
Well, Dr. Thomas, thank you very much. It's all the time we have. We'll see everyone next week.